Dobré ráno, vážení přátelé.
Anglicky.
And very nice morning. Actually, we are in a private session, right? Like 20 people here. But despite that fact, it's much better for us to discuss, right? So let me open the first session, which is debates. We have two debates about GP ablation to improve the results of AFib ablation. And then we have a debate about the management of VT storming. So the first debate will be done by Hiroshi Nakagawa and Petr Peichl. So as usual, the pro speech will be the first. So actually the debate is about GP ablation if they improved the results of our AFib management. Okay, please, Hiroshi, it's your podium, it's yours. Thank you.
Yeah. Thank you, Peter, Joseph. May I have my first slide? Okay, here's the Cleveland Clinic, Cleveland, Ohio. This is the main building. Our EP group office located second floor. We have 9 EP laboratory, number 10 EP lab coming soon. So we have 20 EP faculties. So it's, I used to be University of Oklahoma 28 years. I joined the Cleveland Clinic 2 years ago. The setting is quite different. I'm still new in Cleveland Clinic. And here's the debate title. Here's my disclosure. So debate, GP ablation improves the result of AF ablation. My answer, yes. Okay, my goal today, I'm going to prove the Dr. Piper's argument unsubstantiated. Dr. Peichl does not even believe in what he says. And the end of the debate, Dr. Piper agrees that GP ablation works to improve the result of ablation. So the recent experimental clinical studies have shown that the intrinsic cardiac autonomic nerve system, which is formed by the interconnected clusters, the autonomic ganglia, known as the ganglion plexi or GP, play an important role in initiation and maintenance of atrial fibrillation. Let me show the one by one, okay? Here's the location, the left atrial ganglia. And importantly, GP composes the efferent parasympathetic neuron as well as the sympathetic neurons, and also a bunch of the interconnected neurons. Here's the Marshall tract GP is located along the appendage ridge, superior left GP, anterior right GP located in front of the left atrium, inferior right GP, and the inferior left GP. And the GP contains the cell body and also axons, the interconnecting each other. So again, GP is located epicardial surface of left atrium as well as right atrium and covered by fat, and again, axons heavily innervate into the pulmonary vein. So what's the role of the GP on initiation of AF? So this is the, when I was Oklahoma, here's Oklahoma, the hypothesis, calcium transient triggering hypothesis. And the increased G activity enhance the, increasing acetylcholine and the norepinephrine release. So therefore, the action potential duration significantly shortened. At the same time, the sympathetic neuron activation increased calcium loading, resulting the increase the calcium transient and the short action potential resulting in the early after depolarization. Then rapid release followed by pause, further initiating the enhancing the calcium transient and resulting in trigger firing. This is the published data 2005, how rhythm from the using Patterson, the microelectrodes is placed in the left superior pulmonary vein and just 1 centimeter for the left atrial side, and they recorded the action potential from here inside the PV and outside the PV, and while you are stimulating the left superior, the ganglion plexi. So even the baseline, the action potential is much shorter within the pulmonary vein compared to the only 1 centimeter outside the pulmonary vein. And doing the high-frequency stimulation, like a 0.1 millisecond pulse, you never capture the atrium, but stimulating the GP, resulting the early after the depolarization and trigger firing, and the trigger firing initiating within the pulmonary vein. And look at the markedly shortened action potential duration. Going back to the clinical setting, this is a typical pattern of the PV firing. All right, here's the short, long, short. So initiating the PV firing in this particular case from left inferior pulmonary vein, very short firing. And by the way, honestly speaking, we don't know the mechanism of PV firing in patient yet. However, as shown in the previous slide, simply stimulating GP resulting the EAD trigger firing, initiating the pulmonary vein firing. All right. So then we just did a GP ablation without PV isolation. Now we suppress the spontaneous firing, and also you see still the PAC coming from the left inferior pulmonary vein, but the coupling much longer. And then ablating all 5 GPs in left atrium completely suppress the PV firing, and importantly, the after GP ablation without PV isolation, in this particular case, AF became non-inducible. This is the old data when I was in Oklahoma, like initial the 100 fresh case for the proximal persistent AFib. Just doing a GP ablation left atrium. The pre-ablation, we observed the spontaneous PV firing, 70% case. Post-GP ablation, without the PV isolation, the PV firing significantly decreased down to the 15%. All right, what is the mechanism of the maintenance AF? You might say LoRa, cafe, GP, or something else. But the experimental study shown that the fractionate aid potentials or cafe are consistently located in the left atrium close to the stimulated GP area. Ablation of the GP eliminate the fractionated aid potential surrounding the GP, suggesting the important role of the GP in the genesis of the FAP. In other words, the fractionated aid potential during AF may require very short local refractory periods or left atrial firing resulting from GP activation. So again, the activating the GP during AFib, shortened action potential duration or refractoriness, and enhancing the calcium transient, resulting the EAD or trigger firing even during atrial fibrillation may produce the fractionated atrial potential or cafe. So we're talking about LoRa. LoRa is a spiral wave. And if you look at the wavefront, the curvature, this is spiral wave, of the wavefront increased progressively toward the location center. So therefore, the velocity decreased aiming into the rotation center. So therefore, the action potential at site close to the LoRa center exhibit the less negative resting member potential and the depressed upstroke, indicating a slow conduction. This is data from the Yamazaki 2007 showing the rotation activity here. Actually, this is during a ventricular fibrillation. But this is isochrone map. And look at around the rotation center, you see the rotation activity by activation sequence, but importantly, rotation center exhibiting the fractionated atrial potential because of slow conduction. So you have like a 4 millimeter tip resolution mapping catheter, this is ablation catheter, you might see continuous fractionation. And then now we have the cross bipolar multiple in the electro like a minibus catheter, like Orion, the Boston Scientific. You might see a rotation activity as shown here. But the rotation center is still showing the fractionated atrial potential. So this is, I have been working the optical mapping at the biomedical engineering group at Tokyo University. And here's during AF, the swine model, and showing the stable LoRa during AF. And this is corresponding isochrone map, clearly showing the station LoRa is located the base of right atrial appendage. And here's the corresponding phase mapping, again showing the stable LoRa. But interesting, the stable LoRa, it has the shorter cycle length on 5 compared to the short-lived unstable LoRa is located here, and the cycle length is much longer, 114 milliseconds. So long-lasting station LoRa often anchored at the thin, thick myocardial interface or anatomical boundary, such as the pulmonary vein ostium. Abrupt change of fiber orientation also important. Myocardial fiber fibrosis, as well as the border at the ischemic, non-ischemic regions. It's more importantly, LoRa became stable at site with short action potential duration or short refractoriness. As GP stimulation, you can shorten the action potential duration, shorten refractoriness. So suggesting the importance of the GP activity to provide the stable LoRa. So the in patients with proximal persistent AFib, fractionated atrial potential, FAP, would be located around the GP. Catheter ablation of left atrial GP would reduce the PV firing as well as the FAP. And then I worked with the Bausen Svelsa, and I made my own criteria more reliably identify the fractionated atrial potential area. It's different criteria for the CAFE. And then fractionated air potential. And then we set up the maximum amplitude and the minimum amplitude threshold interval between the potential for the FAP segment. And we count out the FAP segment over the 2.5 seconds during AF. So maximum threshold 0.2 millivolt, focus on low amplitude potential, and the minimum threshold plus minus 0.03, eliminate baseline noise, and detect all peaks of the potential within the threshold shown here. And the FAP segment defined as the interval between the peaks 15 to 80 milliseconds. And the FAP site more than the equal 40 FAP segment over the 2.5 seconds we recognize as the FAP site. Here's the low amplitude, very fraction, very active deactivation, and we count out the FAP segment 44 over the 2.5 seconds. And in the same patient during AF, inside the left atrial appendage, slow organized rhythm, and just for using this software, one FAP segment. So therefore, this is not the FAP site. So this is a 59-year-old man and long-standing persistent AFib. And here's the last on LSPB ostium. And the ablation catheter is located across the Marshall tract GP area. And a very active FAP potential here as well as here. So they're using this software, just focus on red area more than greater than equal 40 FAP segment over the 2.5 seconds is located 3 major sites. Actually, the superior left FAP area, and the anterior right FAP area, and the area-rich FAP area, and finally, inferior posterior FAP area. We do the GP stimulation using high-frequency stimulation and producing the transient AB block or Vega response, localizing the GP location. In this case, the superior left GP was localized using a high-frequency stimulation, indicating the orange tag. And then anterior right GP is located in this region, and then inferior right GP located this area, inferior left GP located area, and the Marshall tract area is located here. So ablating the GP positive site. Here's the baseline. By doing the 5 left GP ablation, AF organized AT. However, AF again, but this time now the right atrium driving atrial fibrillation, not left atrium anymore. This is before the PV isolation. Then if you go to the right atrium, yes, right atrium also contributing AF maintenance or initiation. We call the SVC RA junction GP is located here, RA crux GP is located here, and the posterolateral GP located here. Then we are ablating the 3-4 3 to 4 RF application, eliminating the GP activity as well as fractionation. Then AF organized the AT, no AFB anymore. And then this turns out the double pre-entry left atrium. And then we made the roof-line mitral ablation, and they eliminated this tachycardia. So this is another case, PAF, 52-year-old man. We have publication Jack 2015. So FAP area, superior left FAP area, anterior right FAP area, inferior posterior FAP area. And the high-frequency simulation identified the GP by demonstrating the vagal response. Ablating in this region eliminate almost all fractionated potential area. In other words, we know how to ablate entire FP area. Simply focus on the GP site, they're eliminating almost all FAP. So in summary, 5 left atrial GP, superior left, martial tract GP, inferior left GP, inferior right GP, anterior right GP are located within the 4 left atrial fractionated atrial potential area. And the 3 right atrial GP, SVC, RA junction GP, RA posterolateral GP, and RA crux GP are also located within right atrial FAP area. GP ablation eliminated almost all FAP. In other words, the ablation of the entire FAP area is not required, suggesting that FAP may result from GP activation. So this is the randomized prospective study, multicenter trial, published the JAC 2013. They randomized the PV isolation only, GP ablation only, and PV isolation plus GP ablation. And this based on the publication, this is PV ipsilateral PV isolation plus GP ablation, superior left, anterior right, inferior left, and inferior right GPs. So up to the 24-month follow-up, and make a long story short, PVI plus GP highest the rate of the freedom of the AF and AT, or the single procedure. PVI, 56% survival rate at the 24 months, but having the GP additional procedure and 74%. Just DP ablation only 48%. If you go back to their description, I think it's this, they're missing like inferior left GP, inferior right GP is located more this way, outside of the ipsilateral isolation. And another randomized prospective study, persistent AF, published in Horizon 2013. This is a complicated study. They performed the randomized the PVI plus GP ablation compared to the PVI plus linear ablation, including a mitral isthmus, a roof, CTI, at the 3 years follow-up. Statistically significant better result for the free of the AFAT PVI plus GP ablation compared to the PVI plus linear ablation procedure. And finally, just talking about the remodeling stuff. AF induced the atrial electric remodeling and promote the autonomic remodeling as well as the inflammation. So that's actually resulting in a hyperactive GP. So these 3 remodeling processes form the vicious cycle, malignant cycle, each participating in the other and maintaining the atrial fibrillation. So therefore, the GP ablation eliminating or suppressing a hyperactive GP, or you can do the lobar vagus nerve stimulation, suppress the GP activity, then resulting in the prevention, the progression atrial myopathy. So in conclusion, ganglion plexi plays an important role in initiation and maintenance AF and provides both the substrate and the trigger for AF. The benefit adding GP ablation to the standard PV isolation procedure for the patient with paroxysmal and persistent AF is supported by both experimental and clinical data. AF induces atrial electric remodeling and promote the automatic remodeling as well as the inflammation. G3 remodeling processes form the vicious cycle, each participating the other and thereby maintaining AF. Autonomic neuromodulation by GP ablation may resolve the autonomic remodeling and inflammation and suppress AF, preventing a progression of the atrial remodeling in AF patient. So my answer, yes. Thank you.
Thank you very much, Hiroshi. And now Peter Peichl from Etienne. You know him.
So can I have
I
my
forgot
slide?
to introduce Hiroshi as a Cleveland guy, right? Because you mentioned several times that there are data you're showing us from Oklahoma, but to let people know that you are in Cleveland.
Yeah, thank you.
So hello. I have a tough position. I'm going to debate a GP expert. His name is under many papers, many seminal experiments, very nice experiments. And when I was given this role, I knew that I will be in tough position. So here's the mighty opponent. He can easily crush me. He did it in the very beginning. But in this story of Goliath and David, maybe there is a chance that even I can present some data and maybe convince you that there may be some parts also on my side. So, no doubt that autonomous nervous system plays a huge role in initiation of some of the AF that we see. This is example I chose from my clinical practice. This is a Holter monitoring of a young patient during the night. There's a burst of ectopy, probably short burst of atrial fibrillation, and it's accompanied by bradycardia and also low AV conductivity, which means that there is probably common cause, which is a high parasympathetic tone. But this is not the exclusive mechanism for all AF. So they say this vaguely mediated AF is up to 27 patients that we included in ablation trials, and definitely not in all of them. And I do agree that the autonomic nervous system plays a huge role in some of those AF cases that we do. It has an eccentric, intrinsic component that we may and may not be willing to destroy, and this is a really fine network of different fibers that are interconnected. And the problem, if you go to the EP lab and try to locate those ganglia, the one way how to do it is to use the high frequency stimulation that was shown. But this one usually induces AF, so you generally look for these pauses, to these vagal reactions, and using that you may identify, but it's not that kind of very easy to do because you have to stimulate a lot of different sites. If you can do that also by doing a short burst coupled with atrial stimuli, so you pace during the atrial refractory period, and then if you have a catheter inside the pulmonary vein and you close pace in this refractory period with high frequency, you can sometimes do these ectopics. You can induce or initiate these ectopic beats, and there is an initiation of AF, but it's again not very practical way. It's a nice physiology, but if you're for daily routine, it's a little bit difficult. There are potentially ways how to localize GPs using imaging techniques, like this study that use SPECT, and they use this radio marker to identify the potential size of GPs, and those were, at least in this study, which was a small study, correlated nicely with high frequency stimulation. But this has to be replicated because we know that the nuclear methods sometimes are not that easy to read. But if you look in the clinical practice, because I knew that Hiroshi will bring up the positive studies, so I just took some very recent studies. This is recently 2021 published, 102 patients, and randomized to GP, very, very rigorous protocol, multiple sites pace, looking for ectopy triggering GPs. And when they compared the results between the PVI-only group and the mapping and just GP ablation without PVI, the results were disappointing because the PVI group, which was it's easier today to do it was better. The outcome is 64% with PVI group, and GP was inferior. Although there were some potential benefits, like you ablate shorter, but we can discuss with the current techniques whether this is really really an issue clinically. Obviously, if you take GP on the top of PVI, you may show benefit, and Hiroshi showed you some of the studies that were very positive. I took a really recent one, 2022 one, large study, 225 patients, PVI only group and PVI plus GP ablation, with some benefit over the plain PVI. So yes, there are studies like this, and there are some of them. This is a kind of review of different studies, but not all of them really prove that GP plus PVI is better. No study actually proved that the GP alone is superior to the PVI only. But there's maybe an issue, as was shown also in Hiroshi's presentation. If you do a PVI, you actually do a lot of damage to the ganglia. And we know that, not maybe directly from the studying the GPs, but if I just go on very basic level, we know that the plain PVI is affecting the heart rate. And if you do either RF or cryo, your heart rate increases about 10 beats per minute. It's not the same as the GP ablation, but it means you modulate the autonomic system of the heart quite a lot. You made the nerve, the sinus node or AV node, and this is somehow kind of after 3 months that is lowered, but still it's a kind of substantial. And it has been shown that when the rise is high or the change is high, it's correlated with better outcomes. So there may be a kind of hypothesis that if you do better denervate and more modulate the ganglia or whatever the system in a way, you may get a better result. But that's maybe not true, because that may be not kind of causal effect, but they may be just a collateral effect of PVI. And to be honest, up till now, it was very difficult to differentiate what's the ablation of the PV, what's the real effect on the ganglia. And now maybe we have a new way how to really study that, and I really look forward, because the electroporation is a novel system or novel method of doing these procedures, and we know that the nerves, neural tissue is up to 9 times less sensitive to myocardium. So for the first time, we are able to really have a muscle lesions without really affecting the nerves. But is it true? Well, we'll look at that, and these are very initial data that we presented when we had the opportunity to use the electroporation system and pulse field system, and we analyzed 45 patients and compared the RF patients with the patients that were done using electroporation, and we just look at a very simple parameter like the heart rate, beginning of the procedure and after the procedure, just to see whether the pulse field really does affect the nerves or the denervates or affects the system. And we found that in the RF group, there was an increase about 10 or 8 beats per minute, but there was nearly none in the pulse field group. So we probably didn't really affect the nerves of the heart or the whole sequence or the whole kind of pathway. And in terms of the recurrences, there were, I know it's a very small numbers, but there was not a red flag that not affecting the nerves really affect the ablation effect. So this is one argument that we actually have a now way how to affect the myocytes only that may be good enough for ablation. And the other, we try to expand this, and we used extracardiac vagal stimulation to somehow see whether it's really true, whether we can really study this in more detail. So this is a method that is used for cardioneuroablation, when the decapolar catheter is inserted into the jugular vein, and with high-frequency pacing. And in everybody, in a physiologic manner, you can really induce either SA blocks or AV blocks. This is normal reaction. This can happen in anybody just by stimulating their nerves. And the question is, what happens if you do PVI, whether this pathway is preserved or not. And we compared RF energy for PVI and pulse field energy. And what was a small study, it's under review in a journal. But what we found that if you do RF group just by doing PVI by Antra-Vaka, you actually completely eliminate these reflexes that I show with the jugular pacing, both on SA node level and AV node level. So this kind of shows that so far we were, with these studies that were shown, we're somehow not really be able to really differentiate what's the PVI effect, what's the ganglion plexi effect. But what's shown in here, if you do pulse field, you have some transition kind of stunning of the nerves, but if you wait long enough, it was a part of the study for 20 minutes, you actually get all these reflexes back. So you eliminate muscle, but you don't really eliminate the nerves. At least the pathway is preserved, but still you can, with vagal pacing, you can still have some effect. And the question is whether PVI, by not affecting probably the ganglia on the vagal nerves and these things, whether they do hamper, they do impair this with their outcome. And the answer is probably no, because these are the data from the long term with the Petr Neužil is here. So the results are quite good. There's still 15% of patients that still have recurrences, whether this is the very super special group that needs the very hyperactive ganglia that needs to be ablated. We don't know. That's a very interesting population to study, I believe. So maybe this population may benefit, but the rest probably may not. And there is a reason why not, because we know, and it was shown also by Hiroshi, we know that we may actually preserve this kind of pathway. This is the experimental and then randomized trial showing that the low level vagal stimulation actually can be antiarrhythmic. So taking out all these reflexes, taking out the ganglion plexi in everybody may not be a good thing, because then you take out this physiologic mechanism that may be there. There are different reasons why the low-level vagal stimulation may prevent arrhythmias. But if you just do the ganglion plexi ablation in everybody, you may just lose it, and maybe that's not a good thing in the larger population. So let me conclude. I do agree that the autonomic nervous system plays an important role. And so far, it was difficult to really differentiate what's what. And with the electroporation on board, I believe it's nice time to design nice experiments to really differentiate whether the ganglionic plexi should be ablated. I believe not in everybody. Maybe in selective population, yes. Definitely patients, there are out there that will need it, but this is up to be decided. Thank you.
Very good. Thank you very much, Peter. So, Hiroshi, can you react? Do you want to react? Not really?
Oh,
yes or not? Please come here. So, I have a question for you, okay? So maybe we can guess. So after you hear all these presentations, or two presentations, so do you think for you in your clinical practice, GP is important, and you would add something beneficial to your procedure? So please just say, or if you see the benefit, how many of you would guess that GP are so important to ablate? Please. Okay. Okay. Some, and who didn't? Who wouldn't? Oh. Okay. So there are some guys say yes or not. Okay. So I think it's interesting. Actually, if I can comment, Peter, you said several times nerves. Okay, but we need to discriminate axons like nerves, really like conducting, like nerves, and neurons. Because we can affect somehow even neurons, not only just transient effect, but when you change the voltage and, pulse duration of the pulse field, you can eliminate even neurons, but in different thresholds. Okay, but we need to observe that. We need to investigate that. Okay, but actually you are precisely right, because with this pulse field, now we can really distinguish what we are doing with the ganglia. Okay. Hiroshi, can you comment this?
As a debate, if you just do the PBI or a little bit intra-isolation, you are ablating primary axons, not ablating cell body. As you know, axon regenerate. Cell body unlikely. So therefore, the targeting GP has a benefit, for the preventing the regeneration of the axons. So therefore, look at the maybe 3, 4, 5 years follow-up data might have better impact to the reduce the AFL currents, and as well the may prevent the atrial myopathy or atrial remodeling progression. Although we don't have direct evidence, but that's our hope. So again, PBI or intra-isolation, more likely you partially ablating the axons, but not cell body. But GP is located more proximal atrial side. So that's the targeting GP, its importance. And I agree Peter, doing the high-frequency simulation, identify the vagal response, very honestly speaking, it's a tedious procedure. But also the sensitivity is not enough, because we're looking for the transient AV block. So if you don't have the innervation to the AV node much, even though high-frequency simulation should shorten the action potential duration or refractoriness locally, but unfortunately, clinically, we don't have a good clinical tool to identify the shortened action potential duration by doing the high-frequency simulation. So therefore, we rely on the transient AV block. So that's a problem right now. So therefore, yes, it's a tedious procedure, and everyone to do quick and easy, like a PFA, fast shot, you eliminating entire pulmonary vein potential. Although we don't know the durability yet, but I agree with Peter. But having you have young enough, you have energy, adding a GP ablation plus PVI, I believe there are benefits for patients.
Just the comment to the regeneration of axons, obviously that's an option, but if there's no muscle cells in the pulmonary veins anymore, even if the axons do regenerate, there's nothing to really change the refractory period, because there is no muscle anymore, and there will be some fibrous tissue. So that may not, even in the long term, hamper the long-term results. And obviously, we need to see the long-term results of the pulse fields. A new kid on the block, that's not that much is known. There's a lot of enthusiasm. Yesterday, maybe we saw something that was not that nice, and maybe we have to learn more about it. So yes, there are new things, but I believe the whole debate will be much more interesting with the potential novel things that can be learned about this.
I can have comment this global vagal stimulation reflex. You will see it in next live case by Dan Wichterle. And it's an endpoint. Of course, it's not for everyday practice, but it can serve as a nice test of influence of any ablation technology on innervation. And not only on AV node, because AV node is innervated from different ganglia, but for SA node maybe, and mainly. And we have now, we do study of different groups of patients, like cryo, pulse field, and also RF, and there is tremendous difference in abolition or no abolition of this reflex. So I think this will help us, because it's a unique clinical model. It helps us to differentiate the effect on a neural network or ganglionic plexi versus only myocytes and isolation of the pulmonary veins. And it also has to be mentioned that, of course, if you do GP ablation with RF, you do more ablation, you do more lesions. So, and we know that the more you do, especially in persistent AF, probably more effect. So for me, it's still not proof that GP ablation, as it is done, is somehow beneficial, and we have to follow these patients and accumulate more data, doing studies like this, that you really have some clear endpoint.
So I wish I have energy. I can specifically use not only just for myocytes, as we wish to have pulse field in that range of, the voltages we are using now, but actually even more. I really wish to have pulse field energy to be super selective for neurons or the neuronic plexi rather than myocytes. And if we get this, it will be even more important, because then we will see the pure effect of this degeneration. What do you say about? Okay,
There
do we have
there
time?
are surgical
Pepper?
studies
Okay, we need to speed up, right? So
with the chemical ablation of the ganglion plexi. I believe they are out there. So but the surgery is a little bit different than doing this in the EP lab, but because the opening the chest also leads to some denervation, I believe, in these patients, because they have a cabbage surgery. They are different populations. So I believe we should differentiate in doing these procedures. Not all AFs are just vaguely driven, especially they are the young ones that we look at. Okay.
thank you very much, guys. I think I would leave it open, the question, maybe for next workshop. And thank you all. And actually, let's start with second debate about VT storm management, okay? So it's my pleasure to introduce the first speaker, Etienne Pruvot from Lausanne. And the podium is yours. So it's...
Thank you very much.
Thank you.
Dear colleagues, dear Joseph, thank you very much for this nice invitation. It's a pleasure to be here in Prague. And I just need to plug my computer and we'll start. Okay, here we are. All right. Are we there? Beautiful. Okay, so this is my turn, and things are there. It looks a bit small, but it sounds good. Oh, yeah. Okay, so the menu of the day is pretty straightforward. So why am I right? Why Joseph is wrong? And the second part, why am I right? And why Joseph is wrong? So this is a pretty straightforward presentation. So what do we know about VTs? So we know that most VTs arise on scar, on average. Okay, here is mice. On average, 3 to 10 years after a myocardial infarction. And we know that the prognosis after a first ventricular tachyarrhythmic event is much lower for patients treated for fast ventricular tachyarrhythmias as compared to those who were treated for slower ones, and both prognoses were lower than that before any ventricular tachyarrhythmia occurred. We also know that the death rate after a VT storm is around 25% following the first year. So let's have a quick glimpse at VT ablation studies. The VANISH trial, which was published in 2016, included post-myocardial infarction patients with recurrent VTs, and they were randomized into an ablation group or a group where there was an escalated antiarrhythmic treatment. And the study showed that there was a significant reduction of the primary endpoint by 28%. And this primary endpoint was made of death, of ventricular tachycardia storm, and of appropriate ICD shock. And you will know that both ventricular tachycardia storm and ICD shock were nearly significantly reduced, while death rate remains the same between the two groups. In a second study, the VTAC trial, which you know very well, this trial included post-myocardial infarction patients with the first stable VT episode. And ablation, as compared to antiarrhythmic drugs, was able to delay the occurrence of a first VT recurrence as compared to antiarrhythmic drugs, only in patients with a left ventricular ejection fraction above 30%, while those who had a very low, severely depressed ejection fraction had no benefit of ablation over antiarrhythmic drugs. So the first key message I'd like to pass is that ablation of VT decreases VT storm and prolonged time to recurrence. It improves quality of life, but has no impact on mortality, and there is a high recurrence rate over time. So there is plenty of room for improvement. That's why we are here for the last 3 days. So what are the basic mechanisms of a reentrant VT? This figure here on the right-hand side shows you a typical reentrant VT with a central isthmus propagating from the base of the heart to the apex that is bounded by two sites delineating outer pathways on either side. And the interesting part is that these outer pathways have a conduction which is opposite to that of the central isthmus here. It disappears. So what are the players there? So what are the players involved in reentrant VT? It is well known that reentrant VT occurs on the myocardium with scars, as shown here, where the scar is in white and the myocardium or the ischemic border zone is in black. And that there is a sharp transition between isthmuses and neighboring myocardium, which, because of a source-sink mismatch, is decreasing conduction velocity within the border zone of myocardial infarction. Furthermore, we know that ischemic border zone have a severe downregulation of sodium channels, and they have a redistribution of connexin 43. Both are involved in slowing down conduction velocity on the border zone of ischemic tissue. In this very interesting study of 9 post-myocardial infarction who were investigated with non-contact mapping, the authors showed that central isthmuses identified here by diastolic potential here and there, and there, and there. The central isthmuses were bounded by a mixture of dense scar, as shown by those gray islands here, for instance, and here, and lines of functional block. The situation where a central isthmus was bounded by 2 islands of dense scar was very rare, only 1 case over 9 studies. So what are the determinants of lines of functional block? In this study, involving a canine model of myocardial infarction, the authors were able to show that a normal zone, which is a normal tissue, had a normal distribution of sodium channels along the cellular membrane here, as shown here by immunofluorescence. And there. And this homogeneous distribution of sodium channels allowed a rapid and uniform conduction across the normal tissue, while ischemic border zone here, cells, displayed a severe downregulation of sodium channels. And the sodium channels were only located at gap junctions. And this redistribution of sodium channels was involved in post-repolarization refractoriness, in slowing down conduction, and in the creation of lines of functional block. So the authors concluded that any technique restoring sodium current might render the reentrant VT circuit unstable and non-sustained. In a similar setup from a different group, therefore in post-myocardial infarction canine, the authors show that the connexin 43 distribution was normal or was at gap junction in normal tissue here and in the outer pathway of the reentrant VT, while the connexin 43 were distributed along the full sarcolemmal membrane in the central isthmus. Therefore, there was a clear redistribution of connexin 43. And this redistribution of connexin 43 is thought to be involved in slowing down conduction in this tissue. Again, the authors concluded that any technique reprogramming connexin 43 at terminal gap junction might speed up conduction velocity and prevent reentry. We also know that abrupt transition in tissue thickness between ischemic border zone and normal myocardium slows down conduction velocity and stabilizes reentry by itself. So how come? And this is very well shown here, where a thin layer of tissue, that could be a central isthmus, has to distribute a large number of charges to the downstream tissue that could be the outer pathway of your reentry. And the electrotonic current may be so low that conduction block occurs here, creating lines of functional block. And this has been studied in vivo in a canine model of myocardial infarction. And this inset here, there, is a heat map of tissue thickness. And you can see that the central isthmus here has the thinnest tissue in the order of 0.1 to 0.2 millimeters. And this central isthmus is the one that is shown here during the reentrant VT. And you will note that the lines of functional block occurs on the border at the transition between this very thin tissue and the outer pathways, which are thicker. So, in summary, the central isthmus is characterized by a thin layer of myocardial tissue, which displays an abrupt thickness transition with outer pathways, which result in a source-sink mismatch, creating lines of functional block in given conditions. There is also lateralization of connexin 43 and a severe downregulation of sodium current. On the other side, you have the two outer pathways here, which are slightly thicker, right? And they have a normal distribution of connexin 43, and they have a moderate decrease in sodium expression, which result in a moderate decrease in conduction velocity. So my second message is that any technique that might reprogram or homogenize the remodeled perimyocardial tissue might succeed where ablation failed. So what do we know as STAR as a bailout procedure for refractory VT and VT storm? The workflow I'm going to show you has been the workflow used by most centers performing STAR over the last 5 years. And this is shown here. So any imaging modalities has to be used to characterize the substrate: MRI, CT scan, echo, PET scan, biopsies. Then, during the failed ablation, you have to perform a detailed reconstruction of the cardiac cavities and of the arrhythmogenic substrate. That's very important. And this is these detailed reconstructions that are used to, if I can get my math, okay, used to delineate on a 4D planning CT the site you want to submit to irradiation. And this is a case from Josef, from Lausanne, where this patient had a dilated cardiomyopathy with a scarring of his interventricular septum. Once the planning has been done, you can send your patient to various linear accelerators as shown here to treat the patient. There were a couple of case reports published by different groups before the study published by Kukulic and colleagues. And one of the first case reports was published by the Czech group. Then in 2017, Kukulic and colleagues from Washington University published a series of 5 patients in the New England Journal of Medicine. And these patients were refractory to catheter ablation and antiarrhythmic drugs. And they showed that STAR, applied to the arrhythmogenic substrate, was able to significantly and strongly decrease the monthly incidence of VT, as well as the monthly incidence of shock, as shown on the bottom figure here. There were a couple of complications, one of which is irradiation pneumonitis, which resolved in 3 months. Then the same group published in 2019 a series of 19 patients treated by STAR, and they showed a strong reduction in VT burden thanks to irradiation of the arrhythmogenic substrate. However, as you can see there were still some patients displaying VT recurrences. The median irradiated volume was pretty high, 100 milliliters, which is due to the type of linear accelerator used in that study. Importantly, the reduction in VT burden allows the investigator to taper antiarrhythmic drugs. Then the Czech group published a series of 10 patients, most of them after a myocardial infarction with severely depressed ejection fraction, all with failed catheter ablation and antiarrhythmic drugs. And they showed that STAR allowed a strong reduction of 90% of the VT burden and VT storm. But 80% of that population had displayed some VT recurrences. Interestingly, the irradiated volume was much lower, 22 milliliters on average, which is due to the type of linear accelerator used, which is a CyberKnife system. So our group in Lausanne has treated over the last 5 years 15 patients with VTs refractory to antiarrhythmic drugs and catheter ablation. Most of these VTs came from the interventricular septum, which is a site very difficult to ablate, and they were from patients with dilated cardiomyopathy and sarcoidosis. On this series of 12 patients, 9 had recurrences, and we had a chance to restudy those patients. And we showed that the sites displaying VT recurrences were on the border zone of the irradiated volume in 50% of the cases, were remote from the irradiated volume in 35% of the cases, and were on the border zone with an extensive substrate in 15% of the cases. So the next question and last question is, how come STAR works? Originally, we thought that STAR was producing fibrosis, which was preventing, therefore, VT occurrences. However, this was not explaining the fact that STAR was able to treat a VT storm in 1 day or 2. And a group from the Washington University submitted mice heart to 25 gray. And they showed that the QRS duration of the mice decreased after irradiation as compared to the pre-irradiation condition. And this decrease in QRS duration, as shown here, which was significant, was due to improved conduction velocity longitudinally and transversally. And you can see on that optical mapping figures here that there were a decrease in activation time isochrone after irradiation as compared to the pre-irradiation condition. Interestingly, there was no change in action potential duration nor in effective refractory period, suggesting the lack of toxicity of that technique at 25 gray. Then they developed a myocardial infarction model in mice and submitted those mice to 25 gray. And they showed that STAR was able to improve the conduction on the ischemic border zone, as shown here on this square, and that this improvement was due to a faster longitudinal and transversal conduction velocity, which was again significant. When they looked at sodium channels expression, they showed that there was a threefold increase in sodium channel density after STAR as compared to the pre-irradiation condition. Furthermore, there was a 40% increase in connexin 43 expression as well. Interestingly, within the dense scar, there was no change in sodium channels nor in connexin 43. So I will end up my presentation with the following conclusion, Joseph. Okay, the barbecue style of radiofrequency has still some time ahead, but electrical reprogramming using STAR might be the long-awaited techniques allowing sodium and connexin 43 reprogramming at low dose below 25 gray and scar homogenization above 30 gray. Thank you.
Etienne, thank you very much. And now my co-chair, Josef Kautzner, is the opponent. So I would be maybe surprised.
I need this one. So, ladies and gentlemen, you heard very nice tutorial on pathophysiological mechanisms of VT. I will show you more practical clinical data. There are nice theories, but when you have patient with storm, you have to do something and not to discuss theories. And that's why my, of course, answer is definitely no, because I'm a realist. And I read all these papers, I know them, but I do treat patients with storm every week. And we know that this is a broad spectrum of different arrhythmias, different substrates. So it's very difficult to really do even a study which is randomized because you have so many different mechanisms and many different substrates and many different comorbidities of these patients. And also their heart failure is more advanced or less advanced. But with current technologies of ablation and in expert centers, the results are not so bad. Even in electrical storm, which you can see on this left panel, this is from a collaborative study group, 12 centers, high volume centers, and you see that you can get freedom from VT recurrence in 70%, and 1/3 of these patients were treated in storm. On the right side, you see meta-analysis of some VT trials. You see that it prevents storm from recurrence significantly better than drugs, and also prevents shocks and appropriate therapies from ICD. So, and we have our own data that confirm this, and it also shows that the earlier you do the ablation, if you don't wait until storm, the better. And these are survivals after catheter ablation, and this group is a lower risk group because these were predictors of mortality: age, creatinine, NIHA, low ejection fraction, and amiodarone. Amiodarone is one of the predictors of poor mortality or poor outcome, and these patients were treated with ablation before storm, electively, after 1 or 2 shocks. And these are the same low-risk patients without one or no of these factors, and they came in storm. So there is significant difference in mortality. These patients are very sick, old, with all these risk factors. That doesn't matter because then it is influenced by the severity of the disease. So we know how ablation works. And we know that there are some alternative strategies, and we use more or less all of them, except of irrigated needle ablation. And one of them is radiosurgery or STAR. You heard about this first series, which created a lot of enthusiasm. But I would like to stress that the first ever published case of STAR in a VT was in 2014 by Jakub Cvek, who is oncologist in Ostrava, in Moravia. And then we published this paper, which was originated in Třinec, in another center which is close to Ostrava. And if you look at this graph, there is significant reduction, but there are recurrences, obviously. And we had 2 patients who had progressed with mitral involvement and required later surgery. So, but the topic is whether it can be used for management of storm. I expected that Etienne will show his case report where they said that in storm patient they did radiotherapy and the patient remained free of storm. The other case report you can find in literature came from Canada in ARVC patient. A lot of excitement of these 2 case reports. You also heard about this reprogramming theory that you can shorten QRS complex, and they, based on this study, they reviewed cases of ENCORE. This was these 19 patients, and they found that some of them really decreased QRS duration, and that's probably the explanation. No fibrosis, but reprogramming of channels. And they published this ECG and after radiotherapy, this improvement. But I would like to remind you that in this cohort, there was significant reduction of antiarrhythmic drugs. So we all know that if you take out antiarrhythmic drugs, you can change ECG and you can decrease duration of the QRS. Interestingly, there is another study that tries to explain why this could be very early, the effect. And that's a study on rat model, also irradiation with a similar dose. And they did not find any apoptosis or necrosis, but just some ultrastructural changes. And on the contrary, they found prolongation of conduction, not shortening. So who is right? I don't know. We have 2 studies like this. But I would like to show you some evidence which is against. There is a bunch of studies, very nice studies, in animal models showing that the effect of radiotherapy is delayed because it requires fibrosis to come into the place, especially if you irradiate with a dose like 25 gray. Even higher doses were used. And in this study from Mayo Clinic, they found that up to 3 months, there were signs of apoptosis, and a marker of apoptosis like caspase-3 was found. And after 3 months, there was mainly fibrosis and no apoptosis. So it seems that the primary mechanism is so this is from our study, which we published recently. 3 patients died after radiotherapy. One of them died within 3 months, and this patient had clearly demarcated this irradiated myocardium, and this irradiated area was full of macrophages with a positive caspase-3. So it confirms that these patients this patient had apoptosis, and these cells were eaten by macrophages. And after 6 months, you see tremendous fibrosis, which is full of elastin, completely different from post-MI scar, and it's clearly again demarcated. So there is the effect is probably fibrosis and not reprogramming of channels. Even in that early prospective cohort, which I already showed you, that you see that some effects are quite delayed. So it takes some time before the patient gets benefit. And there are some studies that are practically negative. This is from Andrea Natale, 5 patients. You see a lot of recurrences after radiotherapy. This is from UCLA. Again, a lot of recurrences of VT, or the effect is delayed. This was our first patient. We did treat with radiotherapy. It was a patient with fibroma, which was inoperable because of size, but the patient had incessant VT. We were able to ablate one of these morphologies. The other morphology was not ablated, and we did radiotherapy. And this VT gradually stopped after several months. So there were just ectopic beats, and then it stopped. to occur. So this is another proof that it's not acute. We published another paper showing importance of targeting, accurate targeting. This was irradiated before we had the method which, let's say, co-register CT scan with mapping system. We just did it first just visually. And you see that we missed this area, which was critical. But there is a scar after first radiotherapy in unipolar voltage. There is nothing in bipolar voltage, but in unipolar voltage, this is a scar after first radiotherapy, and this is scar after second radiotherapy. So it produces a scar, not reprogramming of channels. This is, maybe it does reprogramming, but scar is the main mechanism of action. This is interim analysis of cohort of 33 patients. We have now about 40 patients. And we did analysis of outcome. And we found that immediate effect was not observed in any patient. And mostly the mechanism is like a VT burden is gradually decreased over months or weeks. And it decreases the number of shocks, there is no doubt. But it's not for treatment of acute electrical storm. And by the way, 14 patients out of these 33, which is 42%, had to undergo redo catheter ablation at mean interval of about 1 year. So it means that we still need probably catheter ablation, and it seems to be that in some patients it's adjunctive, to catheter ablation. So it somehow homogenizes the substrate, and then you can do better ablation afterwards. So we have a couple of patients like this that we were successful only after radiotherapy with another ablation. And this is one patient with a hypertrophic cardiomyopathy initially. It was irradiated. This is before radiotherapy, bipolar, unipolar map, and this is after. And you see this large core is totally that tissue you cannot capture. Here we could capture only this part was dense scar, so we enlarged the dense scar, and this patient had still some slow VTs, and we had to do epicardial ablation with a surgeon in our EP lab because there were adhesions and we could not get there just with puncture. So, and finally, we published recently 3 cases of redo SBRT or STAR in patients with recurrent VTs for different reasons. One reason was this inaccurate targeting. The other reason was a patient with fibroma, which had another tachycardia from the opposite pole of the tumor after, I think, about 2 years from the previous radiotherapy. And the third patient had extensive substrate. And again, even in these 3 patients, there was a prolonged effect. It took about 2-3 months to get the effect. So, and to answer all these questions and get more scientific data, we are currently conducting a multi-center study in Czech Republic. It's a grant project supported by Ministry of Health, and we randomize patients to 2 arms. One is a radiotherapy, and the other is another redo ablation in expert center in 1-to-1 fashion. They are randomized, and we have difficulty to recruit patients to this study because the ablation is so effective. And if we have recurrences, then we only randomize patient. But if they have storm, we usually do another ablation, and many of these ablations are successful, even if it's a third ablation. So we still don't know, but I almost know for sure that it's not suitable for treatment of electrical storm. I agree that it has some role in treatment of these very sick patients with intractable VT, but we believe, based on all the evidence we have, that the effect is predominantly delayed because it requires apoptosis and requires fibrosis to come into the place. And this theory of reprogramming is nice, but it has to be confirmed, and I see no clinical data, or at least a very few clinical data supporting this theory. Thank you very much for your attention.
Thank you very much, Pepo. So, Etienne, so would you like to add some comments?
Yeah, so as usual, the truth is in between, right? And it's very difficult based on such limited data to have a clear understanding of the effect of SBRT or STAR or radiation on the heart. There are quite some conflicting data from the literature. I fully agree with you, Josef, because we are doing the same job at the end of the road, right? The interesting part of it is I believe that there are different effects based on the different linear accelerators. And the CyberKnife system we are using, are really delivering very high dose of radiation to the target because of the tracking of respiratory motion and some part of the cardiac motion as well. And we know from the planning of the radio-oncology that it's easy to reach 30 gray, which is indeed resulting in fibrotic tissue or triggering apoptosis and fibrosis. On the other hand, in Lausanne, as compared to the other centers, we have been working mostly at 20 gray from the beginning. And we are now almost ready to publish or submit our paper, and we show that voltage mapping in redo cases show a slight decrease in unipolar and bipolar signals, but not much decrease within the arrhythmogenic substrate, which did not display any VT recurrences. So altogether, the truth must be in between. I have the feeling that using different level of irradiation, we might go more toward reprogramming, as you said, and there are more evidences than those you showed, or we might go more toward homogenization, which might be really what we are heading for on the long term.
I studied this literature. Interestingly, the very first idea about radiotherapy was from Japanese authors, and they used very low dose, and they showed that there is a change in connexins. And then it takes 1 year, and still you can see this change. But then some other guys came in with the idea that you have to produce fibrosis, and they tested this 25 gray. So 25 gray produces fibrosis consistently. So there's no way that there's experimental evidence, there's evidence from clinical studies. I showed you some of these examples. So I agree that maybe if we irradiate very low dose, it may be changing something else, not creating fibrosis. But all our observations are really in that way that it's delayed. The effect seems to be really delayed. And I must say that since Ostrava is 400 kilometers from Prague, we do not send patients with electrical storm acutely there. But so I cannot say that it was the effect of radiotherapy, but we will see.
Yeah, we in Lausanne have treated 2 patients in VT storm where ablation failed because the substrate was within the interventricular septum. They had dilated cardiomyopathy, and we tried any drugs, any ablation, and so on. And the interesting part of it is that after delivering 20 gray, we were able to extubate the patient within 48 hours for 2 cases. And that's something that really occurred because they were intubated for 3 weeks. Then there is this Korean group. I don't know if you have seen those data. I believe it's not published yet. And they have done the work was looked at gap junction cleft, right? The space between 2 gap junction connecting cells. And they showed that immediately after irradiation, the cleft is increased in size. And this increase in cleft size is really something which is blocking conduction. So there might be different things coming out, and just keep your eyes open. Thank you.
Okay. Thank you both. Actually, we will continue, guys, with the program. We are pretty much on time. So first of all, I will ask Dan Wichterle is probably from the lab. So with this presentation about the update of cardioneuroablation. So he's, Dan Wichterle is probably in the lab, right? Okay. Yes, let's make it, okay?
Hello, dear colleagues. My task today is to give an update on cardioneuroablation. First of all, I would like simply to emphasize that cardioneuroablation really works. It is a promising treatment option in patients with symptomatic bradyarrhythmias if significant functional etiology is suspected. It works irrespective of clinical manifestation and irrespective of EKG phenotype. Professor Jose Pachon should definitely be praised for introducing this treatment method into clinical practice. Concerning cardioneuroablation, there are 82 records in PubMed and almost 500 records in Google Scholar. Because of time limit, I can't summarize all publications. Fortunately, they frequently provide redundant information anyway. The lecture will be focused only on recent achievements and could be subjectively biased, and I apologize for that. Cardioneuroablation for reflex syncope. It is a randomized study comparing the cardioneuroablation and conservative treatment. The study is ongoing, but approaching to the end. Investigators from Grochowski Hospital in Warsaw, Poland, used the biatrial strategy aimed at denervating of both sinus and AV nodes that is tested by extracardiac vagus nerve stimulation. Syncope-free survival as a primary outcome measure is plotted here and clearly favors cardioneuroablation. This is, of course, an interim outcome assessment and that I have by courtesy of Dr. Piotrowski. All patients with syncope recurrence were crossed over to the ablation immediately after the event, so that comparison of syncope burden will not be possible between the arms. Another limitation is single center design and non-blinded design, but in any case, this is first randomized and very important study, and hopefully the final results will be published soon. Efficacy of right-sided ablation of the anterior ganglionated plexus for neurally mediated syncope is another study initiated by Dr. De Bruyne that is ongoing in 3 Belgian centers. How this study differs from the previous study. On top of randomized design, the study is double-blinded because of sham procedure in the control arm. Ablation strategy is very simple, only right-sided without transeptal puncture. Ablation is aimed at denervating only sinus node with sinus node acceleration as a surrogate marker. That is why the study excludes all patients with AV block phenotype of cardio inhibition and also those with permanent first-degree AV block. This, of course, limits the applicability of future results to wide range of patients with reflex syncope. Interim results are unknown so far. Nevertheless, if cardioneuroablation will prove superior to sham procedure, it will definitely be another step forward in convincing non-believers that cardioneuroablation really works, and not because of simply placebo effect of the procedure, but because suppression of vagally mediated bradyarrhythmias. Let me present our own outcomes of cardioneuroablation. Although the study is neither prospective nor randomized, we use biatrial ablation at empirical sites of ganglionated plexi with procedural sinus and AV nodal denervation as assessed by extracardiac vagus nerve stimulation, similarly as colleagues in Poland. This composite graph shows 3 independent survival curves for syncope-free survival, red in for any syncope, blue for syncope after the index cardioneuroablation, and green one the outcome after the last cardioneuroablation. And let me compare this with outcome of recently published pacemaker study with up-to-date device and dedicated closed-loop stimulation. The syncope recurrence rates of approximately 20% at 2 years are comparable in our cohort and pacemaker off-arm of biosync trial due to subgroup of patients with vasodepressoric or hypotensive preponderance. Such results corroborates the clinical utility of cardioneuroablation as a viable alternative to pacemaker implant in selected patients. While previously presented studies are focused on or were focused on patients with reflex syncope, other ongoing studies can be found in clinical trials database that plan to investigate the role of cardioneuroablation in patients with sick sinus syndrome. The multicenter study from Poland will randomize patients to cardioneuroablation or pacemaker implant with primary outcome measure of freedom from bradycardia symptoms. By the way, the center of Dr. Stets is very active in multidisciplinary approach to patients with functional bradyarrhythmias. They probably the largest cohort of patients with prior pacemaker implant in whom cardioneuroablation was subsequently indicated because of primary or secondary need for a pacemaker system implantation, including leads extraction. And I know that they will present their results at upcoming HRS Congress. It really works, and the experience is in agreement with our experience. The other randomized study from Spain will do the same with quality of life as a primary outcome measure, and the multicenter randomized study from China will implant pacemaker in all patients, and cardioneuroablation will be performed only in active arm. And the primary outcome measure will be percentage of atrial pacing. Now, I would like to go back to the Belgian study because my concern is the right-sided only ablation strategy. Hopefully, this will be clinically sufficient, but our data from small technically oriented randomized study in 24 patients, however, suggests that this may not be the case. We used extracardiac vagus nerve stimulation to investigate progression of sinus nodal denervation when ablation was started in right atrium or in left atrium. And you may appreciate that right and left-sided lesions are complementary in terms of denervation effect. And importantly, right atrium ablation was associated with weaker effect compared to left atrium. Another issue in Belgium study is the procedural endpoint of sinus node acceleration. We reported 2 years ago that this surrogate marker doesn't correspond with sinus nodal denervation. For example, small acceleration of sinus rate by 10 beats per minute may be associated with complete denervation. But acceleration, for example, here by 35 or 40 BPM may not be enough. And recently, we replicated this investigation in much larger population, and the results are presented here. Association was really weak. Sinus rate acceleration by more than 20 beats per minute was the best predictor of sinus node denervation, but the predictive power or characteristics were far from the optimum, and the area under the ROC curve was only 0.7. Next couple of slides, I devote to denervation of AV node. It is obvious that this is challenging because unlike sinus node, AV node is supplied by nerves from many directions. Ablation of posteromedial left ganglionated plexus is the clue to success. Ganglion is located in the pyramidal space delimited by the middle bottom of left atrium here, by posterior proximal coronary sinus here, and posterior-inferior segment of right atrium. And we investigated the impact of ablation at all these three regions for AV nodal denervation. Specifically, patients were randomized to coronary sinus ablation followed by right atrium ablation, or vice versa, to right atrium ablation followed by coronary sinus ablation. And finally, ablation at the bottom of left atrium was the last step in all patients. And the results are displayed in this graph. Coronary sinus ablation induces stronger effect compared to right atrium ablation. However, ablation of both regions was mutually additive. By this combined right-sided approach, because I consider proximal coronary sinus ablation as right-sided approach, we modified the innervation of AV nodes significantly, but complete denervation was achieved only in 40% of patients. Subsequent ablation at the bottom of left atrium here and corresponding data here increased the proportion of fully denervated patients to 70%. And in conclusion, all ablation clusters targeting posteromedial ganglionated plexus convey complementary effects. Thus, biatrial cardioneuroablation seems essential for efficacious suppression of parasympathetic modulation of AV node. This study will be presented at ESC Congress 2022. Importantly, this investigation was performed using the method of extracardiac vagal nerve stimulation described by Pashon and using his proprietary neurostimulator. Moreover, stimulation was done not only at the site of right vagus, but bilaterally in sequential fashion. And the strongest response, either right or left-sided stimulation, but usually left-sided in case of AV node, was considered relevant. In addition to practical utility of left vagus nerve stimulation, we tried to quantify its role numerically. Because we use bilateral vagus nerve stimulation multiple times during our procedures in order to follow the progression of AV nodal denervation, we retrospectively found in all suitable patients the moment of newly developed non-responsiveness of AV node to right vagus stimulation, and we collected the duration of the longest pause due to AV block caused by immediately following left vagus stimulation. And corresponding histogram is shown here. In almost half of patients, non-responsiveness of AV node to right vagus stimulation was accompanied by contemporary non-responsiveness to left vagus stimulation. But in the remaining 58% of patients, more or less prominent response still persists, requiring further ablation attempts. This will also be presented in more detail at the ESC Congress later this year. Concerning collateral effects of cardioneuroablation, the report appeared that cardioneuroablation significantly shortens the QT interval. And even more, it was also proposed that it could be potentially used for the treatment of patients with long QT syndrome. Therefore, we looked at it in detail. Cardioneuroablation produces progressive shortening of QT interval during follow-up. But this is mainly because of contemporary acceleration of heart rate, as shown here in the second graph. And when the QT interval was corrected to the heart rate by the Bazet formula, we got this dynamics with temporary QTC prolongation that resembles the QTC profile which was described after the ablation for atrial fibrillation. And this is logical because the heart rate effects of PV isolation are comparable to those after cardioneuroablation. However, one would take into account the methodological problems with Bazet QT correction. Therefore, we designed the study in 30 patients in whom we measured QT interval during constant atrial pacing prior and immediately after the cardioneuroablation to eliminate the change in heart rate and to eliminate the need for any type of QT correction. And the measurement itself were done diligently on signal averaged and magnified 12-lead EKG with the use of digital calipers. And this histogram shows the distribution of QT differences prior and after ablation. And you see that practically all of them are within the range plus minus 10 milliseconds. And the median change of QT interval is approaching 0. Therefore, our feeling is that neither dangerous prolongation nor beneficial shortening of QT occurs after cardioneuroablation. Finally, I would like to point out the utility of ultrasound to navigate the diagnostic catheter in the jugular vein to be in intimate contact with adjacent vagus nerve. This was investigated in Warsaw Center, and I can show these images here again by courtesy of Dr. Piotrowski. In their hands, ultrasound navigation improved the response to vagal stimulation compared to standard fluoroscopic navigation. The corresponding article will appear in the Heart Rhythm Journal shortly. And this is the end of my presentation. I have no take-home message, take home everything what I have just shown. Thank you for watching.
Hello, my name is Peter Peichl, and it's my great pleasure to share with you our view on the topic of ventricular tachycardia ablation and genetic testing. I will try to convince you that there is a role for genetic testing for our procedures, and we have very exciting new data in this field, and I'm very happy to share this with you. So generally, genetic testing for treatment of ventricular tachycardias may help you with a diagnosis, differentiating the prognosis of the patient, risk stratifying the patient, and also for selection of the optimal therapy. Either it should be drugs, catheter ablation, or some therapeutic approaches for end-stage heart failure. And to be honest, the most common scenario for VT ablation in structural heart disease is post-MI. And there we face the problems of large scars and a kind of problem how to really deal with multiple morphologies, and genetic testing there, to the best of my knowledge, is not probably the thing that will help us. But we also face in the EP lab a patient with non-ischemic cardiomyopathies, which are different and they are very heterogeneous. This is a slide that shows that about 1/3 of patients with dilated cardiomyopathy have a familiar kind of disease, so there is a genetic background there. And currently we have more than 50 causative genes that cause it, and some of them are high risk, like those patients with lamin AC mutation. But there's also overlap of the so-called dilated cardiomyopathy to some other cardiomyopathies, which may be included in the non-ischemic ones, like arrhythmogenic right ventricular cardiomyopathy, hypertrophic cardiomyopathy, and so on. If you take a kind of a general population of patients with non-ischemic cardiomyopathy, and we put them to genetic testing, current methods, we find out that the pathogenic or likely pathogenic mutation can be found in 37% of patients. And most common mutation in familiar is the DCM is for gene TTIN, but there are other genes that are more kind of deadly, and those are genes for desmosomes or lamin AC. And this is the data that the most common gene which was has a mutation or was found as TTIN. The lamin was not that common, but in terms of prognosis and risk of arrhythmic events, there was with lamin AC mutation and ARVC or desmosome mutation are with high risk. And this is for the risk stratification of those patients. If we don't look at just the non-ischemic cardiomyopathy, but for patients that underwent ablation with non-ischemic cardiomyopathy, those are the results that we're going to have. This is probably the largest series up to date of 780 patients with non-ischemic cardiomyopathy. And we realized that the diagnosis is not that good, because 2/3 of those patients fall in this so-called unspecified dilated cardiomyopathy. So these are, in terms of the outcome, somewhere in the middle of the different groups. Obviously, this 1/3 can be better characterized. So we have patients with ARVC, which we can very well ablate because the risk of recurrence, despite being high risk for VTs prior ablation, after ablation, they are doing the best. On the other hand, there are some diseases that we are difficult to ablate, and for different reasons. For example, valvular cardiomyopathies based on valvular disease have a worse outcome. And I believe the genetic testing may help to really specify better or discriminate better this group. So far, if you talk about non-ischemic cardiomyopathy and VTs, people usually stick to this classification, which is simplistic or is simplified, but I believe it's relevant for a clinical practice. So in this kind of classification, you can have either anteroseptal scar, subendocardial, or maybe mid-myocardial, but which can be accessed from retrograde or transeptal approach just underneath the aorta. And for those patients, epicardial access has very limited value, at least in our experience, and I believe in many other experience. On the other hand, they may have a patient with non-ischemic cardiomyopathy with dominant infralateral scar, which are laterally positioned like here. And for those, epicardial access is the access to be performed, because you can clearly improve the outcome for such procedures. This is simplistic, but if you look at the different genes and how they create different phenotypes, you find actually that there's an overlap. So there is a kind of scenario when you have a posterolateral epicardial scar, sometimes with RV involvement, and this typical for desmosomal mutations with this kind of subepicardial kind of scarring within the myocardial wall. This would be the endo, this would be the epi. So we have a location of the scar here. But there are other genes that sarcomeric mutation, so-called lamin AC mutation, that has this intramural scar inside the myocardium within the septum, which is sometimes diffuse, sometimes is present all over the place, and they are much more difficult to ablate. These ones we can do from epicardial access. These ones are troublesome for our EP lab. So not all patients with posterolateral scar are genetically based, but some of them are, and the genetic testing can help us to really differentiate. So what are the difficult ones to ablate in terms of the genetic diseases? Definitely is the lamin AC mutation, which is about 8% of familial cardiomyopathies. They present with progressive dilated cardiomyopathy, AV block arrhythmias, sometimes with muscle dystrophy, and the most common symptom is the sudden death or ventricular arrhythmias. And there are some risk factors associated with, we should implant those patients very early on. But even if we implant them, it doesn't terminate the story. It's just starting of the story, because they do have arrhythmias a lot, and those arrhythmias are difficult to do. This is a recent case. We have 42-year-old male with typical, I would say, distribution and of the subaortic scar, and this punk being endo. Epi, there was nothing, there was fat, and we couldn't really get to this summit of the LV. We had to do everything endocardially, and despite the 2 ablations, including endo-epi, bipolar ablation, the patient has recurrences. And this is not the kind of exception. It's actually very typical for those patients with the basal subaortic kind of scarring or substrate. And in this series, which is from the expert centers, 25 patients, exactly 2 ablations per patient, 91% had a VT recurrence within 7 months. So this is very, very difficult substrate or subset population for patients to treat, and it's already recognized in the guidelines. This is from at Cronin recommendation for VT ablation, that if a patient has a lamin AC mutation, ablation is only palliative strategy for short-term arrhythmia control. Once they start to have these arrhythmias, it's better to send them for heart transplant or some other treatment. LVAD is not a good option because despite having LVAD, they will still have the arrhythmias. We had some patients with this. It's difficult to treat them with LVAD on. And so these are difficult ones. On the other hand, we have also genetic disease, and this is a family of genes that code desmosome. So it's described in here, different parts of the desmosome. The most common is a PKP2, plakophilin 2 mutation, which gives you the typical ARVC kind of morphology. This is very easily to recognize using kind of mapping or any ECG characteristics of the typical location of scar in the right ventricle in this triangle of dysplasia, although the apex, at least in our experience, is not that commonly affected. But epicardially, you find very nice, fine late potentials after QRS, which are easy to ablate if you get to the epicardium. On the other hand, these patients, you can do very good job compared to the Lamine AC, because these are data from some time ago when each line is one patient, and you can see the number of episodes prior ablation. 2/3 of those patients had epicardial access, and only a handful of patients that still have a recurrences despite ablation. But there are also some desmoplakin, the desmosomal gene mutations, like in this with desmoplakin, that creates a kind of disc image that involves left ventricle. This, if you would see this whitening around the LV, you would say this is for myocarditis. It's not. It's a genetic disease, and you can find something endocardially, not that many, but most of the stuff happens epicardially. Obviously, this MRI shows it nicely that there is a kind of subendocardial sparing. You can see very nice late potential with long SQRs, and you have to go epicardial to really kind of help these patients. There's not much data about genetic testing in patients undergoing VT ablation. This is one of the largest series from the Katja Zeppenfeld group, about 100 patients referred for VT ablation, and it's not, and about this is still consistent. 1/3 of patients have a likely pathogenic or pathogenic gene mutation, either lamine, titin, or some other ones. And if you have this mutation, the risk of recurrence is much higher. So even if the distribution is similar to what you would expect in non-ischemic cardiomyopathy, having the mutation just worsens your prognosis. And this is not only for VT survival, but also from a prognostic point of view in terms of transplant and death-free survival. I would like to also share with you our own experience. We started with this some years ago to do genetic testing for our VT patients that undergo endo-epi ablation. Generally, the reason there is if you just do both endo-epi, you are sure that you didn't miss anything that could be ablated. And we have this number of patients that underwent the genetic testing, and we found a relevant mutation in more than half. This number is higher than what I was showing you, but for this analysis, we also included the class 3 genes, which means that they are sometimes of unknown significance. But we found that the most common mutation is in the desmosomal kind of family, sometimes giving ARVC, sometimes with the LV involvement. There's a bunch of different kind of genes that might be involved, and about half of those patients that we didn't find anything, and there's some other diseases that are in place. And these are these genes that we are able to identify. They cause different terrible diseases. They can have a variable phenotype. You cannot really recognize them anyhow, only just by gene testing. And maybe by aggregating of the data, we can learn how to understand these diseases better in terms of arrhythmias. These are the baseline characteristics of our group, of our 87 patients. And generally, those with desmosomal mutations are younger because they manifest earlier and they have more RV involvement, not that LV is that much involved. Those with non-desmosomal mutation are worse in the terms of ejection fraction of the left ventricle. These are the results. So in terms of the VT recurrence, and this is very long follow-up of 6 years, we can find that those that have a epicardial access and desmosomal mutation, they do quite well.
I mean, this is reasonable after 6 years to have a kind of 80% success rate. I would be happy with this. And on the other hand, those with non-desmosomal mutation, I mean, Etienne and so on, they have a very poor outcome. Actually, at 3 years, there was no single one that would be free of arrhythmias. And those without genetic mutation is somewhere in the middle. And this is also transferred into the kind of prognosis. All cause of death and heart transplant is worse for those patients with non-desmosomal mutation. And there may be potential explanations. Why is that? Maybe because in some of those Etienne mutations, the arrhythmias may appear only in terminal phase, so they're sicker. That's why they do so poorly. And also some of these genes that we found had the so-called typical channelopathies with sodium channel, potassium channel, and they actually can worsen some other pre-existing scars. So that's why it's difficult to ablate them. And the question is, if ablation fails, is there other way how to treat these patients? Maybe yes. I've just showed 2 examples. This would be a very strange ECG with a lot of ectopy, with strange P waves, and the patient had this ectopy-induced cardiomyopathy with low ejection fraction. And you can try to ablate, but you fail because this is genetic disease. This is so-called multifocal ectopy Purkinje-related premature contractions due to the sodium channel mutation. And what's important here is this is very good treatable, very well treatable with hydroquinidine, and in this patient, the ejection fraction improved because it suppressed the ectopy that originated from the conduction system. This is different case. You can see a lot of ectopy of different morphologies. You can say this is from papillary muscle. Papillary muscle are difficult to ablate. The patient actually had 3 unsuccessful ablation of the ectopy, and this is also not ablatable disease. This is potassium channel mutation, Anderson-Tavil syndrome, which is sometimes referred as a long QT7 syndrome. There are some dysmorphic features which we not generally look at the cardiology clinic. But again, this is very well treated with flecainide, and you can start these drugs if you know that's this specific kind of disease. So let me conclude that genetic testing may significantly improve the diagnosis of some of the arrhythmic syndromes. And surprisingly, it's about 1/3 of those patients with non-ischemic cardiomyopathy that have a identifiable relevant genetic mutation, and even just was for the family screening, this is relevant. And as I show you, some diseases can be very well treated with ablation, some not, some can be treated with drugs, and this is ongoing thing, and we believe this may very be relevant for our patients. Thank you for your attention.